Bueno, a continuación tenemos dos charlas que me hace muchísima ilusión presentar. Van a ser impartidas por dos mujeres a las que admiro profundamente. Las dos son, bueno, primero podrían, por los trabajos anteriores que tenían, podrían haberse dedicado a la vida contemplativa y decidieron seguir otro rumbo, decidieron dedicar su vida a ayudar a otra gente. Ambas son extremadamente trabajadoras. He tenido la oportunidad de tenerlas cerca un tiempo y de verdad he visto poca gente con la capacidad de trabajo que tienen. Y otra cosa que tienen en común es que las dos decidieron que no podían esperar todo ese camino que os ha presentado Pepe, porque había un montón de pacientes esperando. Bueno, la primera de estas personas es Mara Gordon. Mara trabaja en California. Es ingeniera de procesos, de formación, y llega al mundo del cannabis terapéutico como paciente hace 6 años. Y decide compartir su experiencia con una población enorme de pacientes en un contexto legal favorable. Estamos hablando de California, después del 96. Y funda, en ese sentido, funda una organización sin ánimo de lucro, de mutuo beneficio, es una figura legal en California, que se llama Tía Zelda, On Zeldas, como os digo, con sede en California. Desde la fundación de esta asociación han tratado a más de 600 pacientes y lo han hecho de una forma ligeramente diferente a cómo se hace en el Estado. Ellos hacen un registro exhaustivo de todos y cada uno de sus pacientes, hacen tratamientos personalizados con productos cuya composición conocen, saben lo que les están dando a los pacientes y sobre todo hacen un seguimiento médico de los pacientes desde el principio hasta el final, de forma que pueden saber no solo lo que les están dando, sino lo que está funcionando y lo que no. Bueno, es un placer enorme para mí presentar a una de las personas más trabajadoras, inteligentes y valientes que conozco. Mara.
Gracias, Cristina. Oh, gracias. Thank you. I'm going to try this. Gracias a Carola y al Observatorio por incluirme en este evento tan importante. Me siento honrada de estar aquí. Por favor, perdónenme por cambiar ahora a la inglés. So the question that I'm going to answer today, or to at least address an approach to, is can cannabis medicine be accurately and consistently dosed? As you've heard from other speakers today, it's a very complex plant. We're being held hostage to not be able to conduct effective and worthwhile clinical trials. So in the meantime, what do? How do we approach this plant as a medicine? And that's what I'm going to try to achieve today to explain to you. Okay, so back in 1996, the California passed something called the Compassionate Use Act, which made it possible for people to use cannabis as medicine. This brought a second, what we call the green rush to California, where people were rushing from all over the world and all over the US especially, to come up with ways to make cannabis into medicine, but more importantly, ways to make money in cannabis. This introduced this was the act, this was the Compassionate Use Act, and it's pretty much in its entirety. There was a few more little sentences here and there on what type of doctors, how they had to treat their patients, but basically the most important things to know was that for anybody who was seriously ill in California, they were able to, without fear of prosecution from the government, have access to cannabis. They outlined 8 specific diseases that, as you can see here, are listed for what they would be. But the most important part is for any ailment whatsoever that a doctor found could be helped by the use of cannabinoid medicines. So as a result, there was no guidelines, there was no research, there was no nothing. It's just try it and let's see what happens. And so what ended up happening was you had this 215, it was Proposition 215, which is kind of the nickname for the Compassionate Use Act. And you ended up with thousands and thousands of patients running down to their doctors to get recommendations. It's a very inaccurate number. This slide shows here that as of 2015, there's approximately 750,000 people in California legally using cannabis. It's not an accurate number. The reason for that is you do not have to register with the state. There's two types of registration. There's one where you go to your doctor and he makes a recommendation to you, he gives you a little card, he signs a little paper, and what's happened is it's generated an entire industry of what I like to refer to as a doc in a box. And these are people that are no different than a pill mill, that you go there, you pay your $200 or your $75, or if you have a coupon off the back of the free press, you might get it for $25. And that gives you simply permission to legally have cannabis and have access to cannabis with no guidance whatsoever. Their responsibility ends when they write you this recommendation, which is a very, very poor way to practice medicine. As a result, you have people who do that, and then you have a few people who go the extra mile and they register with your municipalities, with their government agency to show that they have received this recommendation. Because it is still federally illegal, because every county in California is able to enforce the law according to their own local ordinances, as a result, you have people being afraid to register with the state, even though they say it's anonymous. How can something with your picture and your name on it be anonymous in a state database? It's very, very frightening. And so people are afraid for their livelihoods. They're having their children taken away, all sorts of things, so they don't register. So the number is actually much, much higher. And it shows right now in California there's almost 40 million people, and over 60% of the population is in favor of the legalization of cannabis as medicine, and even for adult use. In fact, we'll be voting in November on Proposition 64, which is the adult use of marijuana. And then it'll be a whole different discussion we'll have next year after that. So right here in California, like I said, even with these low, low numbers, it's still 19 people out of 1,000 that are legally using cannabis in California. So what's happened when you had a medicine that was made legal with the added sentence saying, or anything that's deemed possible for it to be useful for? That's the extent of the guidelines that were in there. You ended up with people coming out as snake oil salesmen saying that it would cure this and treat that and take care of this, and you had people making very irresponsible medical decisions based upon what we like to refer to as Dr. Google and Dr. Facebook. You ended up with a bunch of canna celebrities that were they were marketing themselves and becoming very well known and varying authorities, things like Rick Simpson oil and, Run for the Cure and all these things saying but this was all just people talking with no evidence. And a lot of times they were selling something out of their drawer or out of their purse that they were selling, that they were making in their rice cooker or their garage, and it was not exactly medicine. Cannabis is not a panacea. It does tremendous good for a lot of diseases. It works very well for many, many, many things, but it doesn't work for everything. And the danger is when you have access to only poor anecdotal information from something like Facebook, and you have a disease and you have a diagnosis that's very severe, where there are traditional medicines that, yes, the side effects may not be fantastic and cannabinoids can help with that, but the difference will be being able to treat it and go on and live a long life, or feel better and die while the disease continues to progress. We've seen some of this, for example, in Parkinson's, where people have been using cannabis and then they feel much better, so they stop taking their anti-Parkinson's medications, and the disease continues to progress at a much more rapid pace. And it's an unfortunate situation, because if they would just do both together, they would have a longer life and feel better during that time. So instead, these are the diseases right now. Of course, I personally have never treated mad cow, but we don't have a lot of mad cow in the San Francisco area. But these are the conditions that have been found to be very, very much benefited from the use of cannabinoid therapies. So now we have Governor Brown, who's the governor of the state of California, has signed into law a new law called the Medical Cannabis Regulation and Safety Act. They've set up an actual Bureau of Medical Cannabis Regulation. They've assigned somebody as the chief of it. You have a couple of people. They're putting a staff together now. And what they're doing is they're creating a series of licenses and regulations within the state. So no longer will it be the same person who's growing them in their garage and then processing them and then going to a show and selling them, whatever. Everything is going to be regulated. Who can grow, how much you can grow, how and in what conditions. We have a very severe drought situation, for example, in California. And these guerrilla grows that people are having, that they're doing out in the middle of the forest, and then they're using heavy pesticides, and then with the runoff and no concern for what it's going for the groundwater, it's a very, very, very serious problem we're having. With this, you're going to have people that are actually able to have regulations and laws around what they're doing, so when they go to bed at night, they don't have to worry that is there going to be somebody dropping down out of a helicopter to come and arrest them? Are they going to have to worry about having their things stolen? Whatever. It's going to be a much, much better situation overall. But what's ended up happening is we now have a land race sort of a situation where you have people racing to be the ones to get these licenses. And these licenses can be very expensive. So there's a bit of a problem with having access to it for some of the people who have been around for a very long time in an underground environment to now becoming, as Steve D'Angelo says, out of the darkness and into the light, to be a part of a regular economy and paying taxes and all these things that these people, some of them haven't done in 30, 40 years, are now going to be expected. They have an opportunity to do it. Whether they'll join the regular economy or not is still yet to see. Hopefully it won't end up all in the hands of the big giant corporate farms. That's the one consideration we're having by these different licenses. So how do we do it? To go back to what my original, the question was, is how can we accurately and consistently dose cannabinoid medicine, considering that we're living in a state of chaos right now with the way that research is being done and being allowed? So the first thing we do is we begin with lab-tested medicines. Very, very important. If you do not lab test, you do not know what's in it. You can have medicines that are very well prepared from medicines that were very well grown, but if you do not have test results to show what is in that, it's a very complex plant. It has hundreds of compounds in each one, and there's no way that you can know from looking at a plant or smelling a plant or tasting a plant what's in it. And frankly, when you're talking about medicine, it isn't about how you feel, it's about how you can verify things are. As a result, here is an example of a lab test on the left for a high THC and on the right for a high CBD, and I'm going to show you here. Here we're looking at the THC level at 67% on this particular one, which means that in each gram of the medicine, we know specifically that there are 674.141 milligrams of THC. That's a very specific number. We know here that there is no CBD in this particular one. Here you have the THC at a much lower, because this cultivar happens to be one that's a high CBD plant, and as a result, it still has in there 2.8%, which is 28.757 of CBD, and then, of THC, and then on the CBD, you have 653.043 milligrams. So if you're going to go dosing this medicine, you know what you're dealing with. And then behind here, to go back up, I want to show you on the bottom, these terpene charts, this is all the terpenes that this particular lab is testing for in these medicines. So not only do we know what's in the plant as far as the cannabinoids, we also are able to know quite a few of the terpenes. Different labs test for different ones. That'll be moving towards standardization as well. We look at the metals and the pesticides, molds, mildews, because you can have a really wonderful medicine, but if nobody caught that there's a serious mold, it can cause death. It can cause severe lung disease, especially to people who are immune compromised. It's a fantastic medicine when it's done right. When it's done poorly, it can be very dangerous. Fortunately, there have been no known deaths from the cannabinoids, but sometimes what they're grown, what they're made with, or what they're processed with can be the problem. So the second thing that we do is we do an in-depth patient intake process. So what does this involve? This involves looking at everything from the demographic information, sort of things that you would need, like name, date of birth, these sorts of things that help you with your information gathering, but also you have to have very specific information about the diagnoses. We have to know the staging of what diagnosis, if there is staging for the particular ailment that you're treating. We also take a look at all the medicines and supplements that a patient's taking. This is very important when you're working with cannabinoids, because CBD in particular acts very actively on something called the cytochrome P450 for interactions with other pharmaceuticals. About 50%, don't quote me on that, about 50% of all pharmaceuticals are designed to be processed and metabolized through this process in the liver, through this enzyme. And because CBD acts so significantly on this, it may be that you either need to take the medications at different times, several hours apart, or it may be in some instances where your pharmaceutical dose is adjusted, or in some cases, in cases of particular chemotherapy agent that we came across, you actually are better off changing the drug that you use so that the drug will not lose its effectiveness. So that's why it's very, very important that when you're doing an intake that you also take a look at what are the different supplements and medications that a person is on. We also, of course, get their cannabis history, their cannabis use, because it tells us a lot about where we should start on dosing with the patient. So all these things, we're getting military service, we're looking at PTSD, exposure to toxic chemicals, war zones, things like that. So we're getting about 300 different data points right now. So then it's also very important that you understand the effects of cannabinoids and terpenes. I'm not saying that we all have to become botanists or endocannabinoid specialists, but to have a basic either reference, the same way that if you go to the doctor, oftentimes they pull out of their pocket their little book of all the pharmaceuticals and they see which one matches which. There's no reason you can't access these same things. Fortunately, we have these available electronically, so you don't have to pull a little book out of your pocket. It's not very good for your dress line, and I don't usually have pockets, so I'm glad I can just put it all in my phone. But what we're looking at here is the life cycle of cannabis. This is a very simple. I know that we were talking earlier about decarboxylation and the difference in the cannabinoids and when they have been decarboxylated and how differently they affect the body, and that as Manuel so brilliantly illustrated, the key going into the lock. So what's important to understand is the raw forms where you have like the THCA and the CBGA and the CBDA. There's a lot more research to be done on all these different cannabinoids. However, we know that each of them have their own medicinal benefits. I have here just a few things that I've outlined. And I'm sure the slides will be available, or we can make them available to you, at least this particular one, if you're interested in seeing. It's a very well-known slide. I didn't make it up. But to show, and once the cannabinoids are heated, they then go into the decarboxylated state. The decarboxyl atom is removed, and they have a whole different set of medical benefits. This is where you have the THC and the CBD that we're all been talking about so much here today. And then you have your aged after they, like, for example, some people, we used to think about CBN as what happens to THC as it ages and it breaks down. We used to think that was, that just shows it's old weed, it's just bad medicine, whatever. Well, now we know that CBN is something to be encouraged in the plants because it has so much, it has a slightly weaker affinity for the receptors, but it also has a very good somnolence, so it's excellent for people that have sleep disorders to have CBN. In fact, we're doing quite a bit of experimentation right now with UVA and UVB lights looking to actually create and speed up the process of creating CBN. So this is very simple. And the thing about cannabis medicine is even if it isn't all decarboxylated perfectly, you're going to get benefits out of it in one state or the other. For example, THCA. We have quite a few patients that are using THCA along with the other cannabinoids. For example, they'll juice the fan leaves. Children that have epilepsy often have, at the same time, they're having a lot of problems with their stomach, their gastrointestinal issues, and THC has been shown to be very, very beneficial with gastrointestinal issues. So, I mean, they each have their own benefits as well. So even if you don't take it exactly right, you might not hit exactly what you're trying to, but you're still going to get a second prize that's going to still be very good. So understand, of course, the entourage effect. I have it on here, but there's never been a known case of Marinol addicts. I mean, it's not a street drug, and there's a reason for that. It's not a very pleasant experience. People will take Marinol or given Marinol to ameliorate the side effects of chemotherapy quite frequently. And they say, yeah, it helped with the nausea, but it made them feel terrible. Well, anybody that knows cannabis, it wouldn't be the most commonly used drug in the world if everybody felt terrible when they used it. So obviously there's something else going on when it's in the whole plant, and you have the combination of the different terpenes and cannabinoids. The terpenes and flavonoids, of course, change and alter the effect and the feel and the experience that you have from cannabinoids. So if you take, for example, the old hippie trick of eating mango 20 minutes to an hour before you had THC, and they would say, oh, I got more stoned. Well, the reason is, we understand, is because it breaks through the blood-brain barrier, and it increases the bioavailability of the cannabinoids. It also, myrcene, which is found in hops, which is a very close cousin to the cannabis plant, also causes us to have a much more somnolent, relaxed effect as well. So if you're for daytime, very infrequently would we be giving myrcene to somebody that's going to go to work and still be functioning with the regular. But instead, we could give them strains that have a higher levels of limonene, for example, which is found in lemons. It's very uplifting. I've told the story many times about how I was in a very bad mood. I was getting on an airplane after a very long trip, and I was exhausted, and I was grumpy, and the flight attendant handed me a wet washcloth that had been scented with lemon, and I held it to my face, and I just immediately felt the benefits of it. So anyone that works with their medicine, you should be able to smell the terpenes. It's a sensory experience as well as having it what happens to you internally. So take that extra second to smell your medicine before you take it. So together they work with the different combinations of hundreds of terpenes and 100 or so cannabinoids. The combinations are mathematically quite significant. And I like to say that we actually have a pharmacy in a bud, because there's so many different combinations of potential treatments within the cannabis plant. We have so much. If we did all of our research, everyone in here took a research project, we would not finish in our lifetimes and probably our children's or grandchildren's. So the endocannabinoid system is quite simple. It has the CB1s are found mostly in the central nervous system, CB2 in the peripheral organs and immune. And as a result, if you know this and you're a physician and you're treating patients, you know as a starting point, am I dealing with something that's in the central nervous system? Well, then maybe THC or something that's a THC-derived medicine is something that I should look at. If it's in the immune, also you want to look at the THC, but also more the CBD because of its anti-inflammatory. So these are the things that you don't have to become an expert, but you can learn from the experiences of others that are practicing this and then take them forward into your own practices. Also, there's charts like this. Now, this chart happens to be quite old. It was done in 2011 by some dear friends of mine at Hayland Labs, which has now been purchased by Steep Hill in California. But it shows, like, if you're looking at, okay, I want to see something that has an anti-inflammatory benefits and what reduces inflammation, and you see your CBDA, CBD, CBCA, CBC, CBGA, alpha-pinene, myrcene, and beta-caryophyllene. Okay, so you know these things. You'd say, okay, so I'm going to look for those when I'm suggesting medicines for my patients. Here they are right in front of me. I can just have a guide to look at. The next thing that we do is that we take rigorous patient records. We keep records, and it makes you, think about it. When you first work with the patient, you might give them a 30-day supply of medicine. You do that so that you get feedback and you see what's working, what's not working, how is it going, where do we need to make changes. Anybody who's a physician who has worked with the patient who's on any kind of an SSRI or on a hormone medicine will tell you, or thyroids will tell you that it's hit and miss till you find which is the right dose for that specific patient. Cannabinoid medicine works very much the same. There's this thing about, you can't dose it, it's not accurate, but the very few pharmaceuticals are one size fits all. Most medicines are bespoke and individualized to a patient, or they don't work and then they give you a different drug. And here we can make alterations. We have a lot more leeway of what we can do before we have to throw it away and try something different. But part of our patient feedback is, yes, you want to have surveys. You want to get this anecdotal sort of information from patients telling you what's working and what's not. How do you feel? Do you feel good today? Did you take your medicine today? And if you did, how much did you take? And are you energetic? Are you sleepy? Are you sad? Are you happy? All these things are very, very important. But not nearly as important is scans and labs and blood work and the reports that you get from their doctors, their other physicians, or from the medical testing to show you how things are actually working at a metabolic level in a patient. Obviously, if the diagnosis that you're dealing with is something like chronic pain, and the person is not in pain anymore, then having them say, I'm not in pain, I feel great, that's wonderful. But if you could also get something that shows an inflammatory marker, or that shows why they're not in pain, what's going on that's happening differently in their bodies, so that we can all learn from it and take it and move it forward. Because frankly, we're dependent at this point upon every cannabis patient who's willing to be rigorous in their record keeping to help us to figure out this plant, because you can't do it from Google. You can't do it from the FDA, that's for sure. You're not being able to do this in any of the standard ways, so this is as close as we've been able to find to get. So I'm going to take you through a case study real quickly through one of our patients. This little boy came to us at age 4. He was diagnosed in, I believe, September 2013. He came to us in December, so he was only a couple months into treatment at the time. He was 4 years old, stage 4, pineoblastoma, which is a brain tumor in the pineal gland in his brain. Was not given much chance of survival. He received 33 episodes of radiation. He had 3 or 4 different types of chemotherapies that he went through, and he used cannabis through it. So initially, we were, a little bit nervous. It was a little 4-year-old. We started him on 100 milligrams of THC and 100 milligrams of CBD. That was the recommendation. And that was how we achieved it. We achieved it by having lab-tested medicines that we were able to know precisely how much to give him of each one of these in order to achieve the 100 milligrams per day. When his dose was later, his dose was increased later. It was increased to 300 milligrams and 200 milligrams after we had some reports from their doctors of where his status was and whether it was enough. We also are able to see that when a person, if you start titrating up some very slowly, if you approach it in a very similar way that Linus Pauling approached the titration of vitamin C, we look at the same way. You start very slowly and you increase. When a person is no longer able to acclimate to a dose, then you back off ever slightly and you find their therapeutic dose. And frankly, that's as close as we can come right now to knowing a prescribed dose, because that's the best we can do with what we have to work with now. So this is how we achieved it. In this case, the same. We were able to do this particular medicine because we knew what was in it. We knew that if he had a quarter of, that's supposed to say grams. Sorry, I don't know, it was late at night when I was editing, but it's 2.5 grams twice a day. He was able to achieve the 300 milligrams. The same here, he was able to achieve the 200 milligram dose that the doctor had recommended. Then he now, at this point now, he is 7 years old. He's been in full remission for over 2 years, and he is on a maintenance dose of 100 milligrams tetrahydrocannabinol once a day, and on CBD once a day of 75 milligrams. Okay, and this is how we've been able to achieve this. He's now moved to a oral, not in the extract because it's in a lower dose and easier to dose with it. And he's able to take a half a mil of one in the morning and a half a mil in the other at night, and he's in school and he's having a good life, and he's just went recently, his family went on trip, and they're just living a normal life. This is a kid that came to us with no chance of survival. Now he's 2+ years in remission, and he's in school. He's getting to go to, and he's doing all this on 100 milligrams a day of THC. And 75 is CBD. So when it's the right dose, you don't have to feel stoned, disassociative, any of those things. You can still feel completely functional if you are in fact at a therapeutic dose. If you're taking it to where you just want to get high, you're taking more than you need medically at that point. So here's his, over time, this is the doses that he was given. And when they started, we did have this intermediary here. The parents on their own, we actually took how much they were actually giving specifically because we wanted to make sure that we weren't, you tell somebody how much to take, and then you say, okay, let me see, what are they actually taking? And so we actually were able to measure it, and they were taking 116 milligrams of the THC and 67 milligrams of the CBD. And he was still in remission with all that after a year, so we went ahead and we just codified and said, we're gonna give you 175, and unless we hear otherwise, that's gonna stay your dose for the foreseeable future. It'll go down over time, but our experience has shown, because I've been doing this for not so long, maybe 5.5, almost 6 years, treating cancer patients, that when they go off the medicine and they stay off of it, their cancers come back. So it's not a panacea, once again, and it's not a cure. The conditions within the body where cancers are able to develop, they do not go away because you're treating somebody with cannabis. You activate the endocannabinoid system, you create apoptosis, you have all these things that cause all these things that happen. But if you stop the cannabinoids, you stop that whole process, because the situation that existed where the cancers can develop to begin with are still present after the treatment. They haven't changed. It's not like catching the flu and then you get rid of the flu and you don't have it anymore, okay? Now, I think it's very important to show that we also, here's examples of the record keeping we had for him. We had treatments, we had MRI reports. You'll see here it's very good. This most recent one report was from the end of August, just a couple weeks ago, and it's showing no residual, nothing. I mean, the kid's a rock star. He's doing fantastically, and we're so proud of him. He's got some damage from the 33 radiation treatments that he's having to deal with, and he has a little bit of a problem with his gait, which is a very common side effect from chemotherapies. They went ahead and they did a check, and it turns out it's a fatty deposit on his spine and has nothing to do with the neuropathy that normally is prevalent with chemotherapy. So it's really one of our really great success stories that we're very, very pleased to be able to share with you today with the family's permission. Now, I want to show you here. Here is a set of brain cancers. These are not all pineoblastoma. Some of these are glioblastoma multiforme, astrocytoma, and glioma, optic pathway glioma. But I wanted to show you the variances in the dosing, and this is the age, and then these are the weights of the patients. And I think it's very important that you see this because there's a tendency in pharmaceuticals to match milligrams per kilogram. And we have not found in cannabis that to be the case. We find that we use a lot more medicine, a lot higher doses of cannabinoids, the younger the patient. Theoretically, the younger patient should be much lighter weight than the adults. So in that case, obviously, there's not a relationship in a milligrams per kilograms. It has more to do with the age, has to do with the metabolization rate of the child or the adult. It has to do with simply the number of cannabinoid receptors that have been developed at that point in the body.
There is a critical gap between physicians who treat patients with cannabis and patients who find symptomatic relief from those treatments, and dispensaries that sell cannabis products. Lack of knowledge and transparency. Meaningful and validated information that connects the science of cannabis, the impact of treatment, and the availability of the right medicine. This is CDR Med, the missing link that allows for physicians to meet their patients' needs. For providers, the CDR Med platform serves as an electronic medical record solution, capturing in-depth patient history, current medications, cannabis usage, test results, family history, and lifestyle. CDR Med then deploys a proprietary algorithm to create a custom cannabis dosing treatment plan. If there are potentially harmful medicinal interactions, CDR Med identifies them and alerts the physician. Physicians are armed with the ability to accurately create the treatment recommendation so that patients can access the dispensaries with products that match. And once patients have product observations and treatment outcomes, CDR Med lets patients share them, giving their provider a deeper understanding of what is working and what to do next. For dispensaries on the CDR Med platform, treatment plans are immediately accessible at the dispensary. So when the patient arrives, they understand what products they need and what products are available. And when patients walk in without a treatment plan, CDR Med puts the power of data to work through a dispensary platform that helps staff incorporate patient symptoms, medications, and objectives into an immediate treatment recommendation. CDR Med, a trusted clinical resource for caregivers, a data platform that empowers patients, a safe and transparent one-stop shop solution advancing cannabis-based patient care.
So, sorry for no intro to that. I didn't know it was going to just start playing. So that is when I first started this, my background is I'm a process engineer. So the question that I wanted to answer from the very beginning is, can we accurately and consistently dose cannabinoids and terpenes across patients, across time? That's the million-dollar question, right? That's the question that we've all been trying to answer. Every one of these things that we go to, every study that we're doing is, how do we dose this complex plant? So as a result, my natural tendency, of course, is to build a software platform around it and figure out a way to collect the data, to start writing the algorithms and figuring out a way to do this. So we've created this CDR Med solution. We're making it available to governments, learning institutions, hospitals, doctors, pharmacies, dispensaries, anybody who's going to be involved with making decisions around this plant, research around this plant, dosing and making recommendations, or actually dispensing it, so that we know that from the whole way through that what the person needs based upon their medical condition is what they're going to be getting, and then we can track what's working and what's not working. At least that's the theory. So far, we've been using it internally in my organization for quite some time now, and we treat a lot of patients, and it's been extremely helpful. It's going into beta, and it's not here to do a plug, but it's to show you that there are things coming. We are, in fact, there is research going on that is real research that may be not FDA approved, but it's also not Dr. Google. So there's somewhere in between where we're creating it. We're having some observational studies that we're doing right now, looking and doing the analysis of our current data that we have on patients. And we're in the midst of getting what we call an IRB, which is an institutional review board, which is an ethics committee, to have the ability to actually do the study and report on what's working and what. We're starting out initially, we're going to be looking at GBMs, glioblastoma multiforme, brain tumors, as our first analysis, and since we have such a large group of those patients. But I hope that what you find here today in the conclusions is that it is possible to dose consistently and accurately, okay, and correctly. If you have lab results on your medicines, and without lab results, it's really not medicine. It's just, it's just a guess what you're going to get, and it's never going to be the same twice, and it's certainly not going to be the same time 3 times in a row. You have to have accuracy and consistency, and you must have standardization and regulation in this. It's very important that we have regulation so that you don't have people operating out of their back rooms and their garages and using caustic chemicals and solvents that are poisons to make their medicine because they're cheap and easily available. If we have regulations, then we can at least take a look at consistency in labeling, consistency in disclosure in solvents and what things are made with. It's extremely important. You also have that we show that if you have the activation of the endocannabinoid system, that you actually can treat many, many diseases. Not every disease, not every part of every disease, but you have many things because the endocannabinoid system is involved in so much of our body. The entourage effect is essential. None of us would choose Marinol over lemon haze any day of the week because it just does not work as well, it doesn't feel as well, and you're not going to have the successful outcomes from it. And it's important that you do have the right combinations of terpenes and cannabinoids for you. It is not a one-size-fits-all, and without THC, most diseases would not be treatable. I don't know that I'd really emphasize that here that much, except for you could see in this cancer treatment of 300 of THC and 200 of CBD. But it's very, very unfortunate what we're seeing around the world, and a lot of in the United States, I believe 17 states at this point, that are only having CBD laws because we have somehow this craziness that having psychoactivity, having a feeling is a bad thing, or having a positive feeling is a bad thing. It's okay to feel terrible from your medicines, but you can't feel good. So euphoria has become a negative side effect in our culture. And as a result, you have many, many people who do not have access to the types of medicines that they need for their diagnosis. Yes, it's wonderful that CBD does great for epilepsy. It's fantastic that it does for so many, many conditions. But without THC, most people are going to be left without help and without hope. We do have to have a lot more research. We must have more research. But in the meantime, we need access to safe medicine, and we need that now. Thank you.
Tenemos un par de minutos para preguntas para Mara.
In the first place, thank you for all your work. And I was wondering, you mentioned CBN up here. Sorry.
Sorry, that's okay.
So you mentioned CBN, and I was reviewing some data on the carboxylation process, and I noticed at 115 degrees Celsius, there's a sharp drop on the THC after the 30-minute mark. So does that mean that it's quite possibly transforming really into CBN? Will that be an adequate method of obtaining CBN then?
It depends, okay? CBN is decomposed with time and light, and decarboxylation is heat, okay? So when we're decarboxylating, we also have to be very careful that we don't over-process it to where we burn it off. The same way, when something is decarboxylated, you're never going to have as rich of a terpene profile, for example, because they have a much lower vaporization point. So a lot of it has to do with vaporization at that point, not just transference to another cannabinoid. Yeah.
Thank you.
Mm-hmm.
Yes. Thanks. Yes. Thank you for the brilliant presentation, Mara.
Thank you.
I actually have 2 questions, if I may, and I'm not sure if you're the right person, but the first one has to do with your presentation, terpenes. Mm-hmm. Do we have any opinion at the moment as to whether a terpene from another source outside of cannabis is as effective as the terpene which is found in cannabis in its natural source? That's the first question. Do you want the second one now? Or?
Sure.
And the second question is, and I don't know if you're the person to be answering this, the concept of the endocannabinoid system deficiency bringing about illnesses. whether or not we're at a point in the science that we have at the moment to be able to have an opinion on that.
Okay. As far as the terpenes, we're doing experimentation right now at Zelda's on adding terpenes. But having said that, we only work with whole plant cannabis, and we only work with plant-derived essential oils that are terpenes that are coming from real plants. We're not using synthetics. We're not using bioidenticals or anything. We're using real things. So, for example, if we make a topical, all right? We make a topical that I have blended 10 essential oils in addition to cannabis into it. I don't have to hear myself. I know what I'm saying. So no, we've incorporated these into them, and with the exception of 2, because they have their own medical benefits, and one is arnica and one is boswellia or frankincense. All the other 10 are essential oils that are plants that contain terpenes similar to what you find in cannabis. For example, lavender has linalool, lemongrass has limonene. There's so many of them that are in this. That we've incorporated into this to bring these other essential oils in that also have the medical benefits. So I really believe that when you're mixing things, to use things that come from other medicinal whole plants is really the way to go. And yes, we do find that it modulates the effect quite well. Absolutely. Eating mango and then smoking a joint. I mean, if it didn't work, the mango wouldn't make them have a different experience than they have without it. Then the second part of your question is, Dr. Ethan Russo has done considerable work in the area of endocannabinoid deficiency, and I find it very interesting and very. It helps to address the question, why are some people sick all the time and why are some people just hardy, Because if there's no other test, then maybe there is a deficiency. We also think that there's a theory that we're throwing around, that it changes up why one person for the same diagnosis might need a much higher dose than another person because of endocannabinoid deficiency. There's a lot still to learn. There's a lot more to, At first I jumped right on it and I said, it explains everything. Endocannabinoid deficiency, that's but we don't know enough yet in every case to say what it is. But it's definitely something that we should consider. And I think it has, especially when you're dealing with so many people in our toxic environment with pollution and poor foods that are having more and more autoimmune diseases, inflammatory conditions, that there has to be some sort of a correlation. But until we do more testing, we just have no way to know. Yeah.
¿Tenemos tiempo para una pregunta más?
Okay. Do you advocate for the patients with cancer? I understood when you said that they should keep on taking cannabis all their life. And have you found headache a consistent or typical side effect in patients receiving cannabis for the first time? And also a different question, do you think overregulation can be a problem if prices for the business get too high and then the underground is going to keep going on? Mm-hmm. Thank you.
Okay, the first question was on, sorry, one more time. The first question was on, I lost it in the second. Let me go ahead and answer the second in the meantime. I know that overregulation is certainly an issue. In fact, we saw in Colorado when they first legalized it, they were overtaxing it. And as a result, people were not taking advantage of the system, and the black market continued to flourish as a result. They lowered the taxation rate, and people were not adverse to then going to the dispensaries. The model there is so ridiculous because the only difference between recreational or adult use in Colorado versus medical patients is the adult use medicine has to be lab tested and the medical does not. explain that to me. Sick people don't get better medicine because they don't pay taxes on it. That the only difference is the taxation, but so their medicine is not as good. And that is a serious problem, which is why I would encourage Spain to not look at Colorado as a model for legalization and rollout, because it's an absurdity that needs to be fixed. Then the first part of your question, I'm sorry.
The first question was if you
cancer and the headache.
If you advocate
Yes.
keeping the medicine, the cannabis, for the whole life
Yes.
in a patient with cancer,
Yes.
and if you have found headache as a symptom or as a side effect when
Right.
patients start with treatment.
It depends on what form they start in. I wouldn't say that having a headache is something that to be expected naturally. I mean, I have had people complain, it's like anything else. It's biphasic. Cannabis, maybe triphagous, is where people might take it and get nauseous, and that can go away over time, or it can be mitigated in other ways. But the headache, it depends on if it's a clean medicine that doesn't have any pesticides or molds or mildews or heavy metals or anything, there shouldn't be a headache. It might be that there's something in the plant, like, for example, I stay away, personally, I'm a cannabis patient myself. I stay away from cultivars or profiles that contain alpha-pinene, because alpha-pinene makes me feel very bad. And it makes me feel very, very disassociative, very nervous, very uncomfortable. So I just stay away from strains that have, or from medicines that contain alpha-pinene. So it may be that if that's something that's happening, that it's worth taking a look at the profile of the actual medicine and finding out what is it in that specific medicine that's giving you the headache. As far as taking the dose for life, right now we have this little boy, he's on 175 compared to 300 and 200, which is still a sizable amount. But he also is still dealing with some issues, like he's having some of his gait problems, some of the others. So we're not quite ready to lower it any further. But ordinarily what we have is somewhere between 10 and 12% of whatever the therapeutic dose was that they were taking while they were going through treatment, that then ends up being their maintenance dose that they stay on indefinitely. The same way, if you're vitamin C deficient, you take a vitamin C supplement. If you're iron deficient, you take iron. And we look at it the same way. Perhaps there is this endocannabinoid deficiency or something, and by taking this supplement, because your endo is not creating, so the phyto or the plant-based is an option to have to supplement what your body's not creating on its own. Yeah.
Muchas gracias. Sé que hay más preguntas, pero tenemos que seguir, lo siento mucho. Mara va a estar aquí todo el día. Si la veis fuera, seguro que responde a vuestras preguntas. Muchas gracias.